Hello and welcome to this special edition of Creighton in the Community. Today we're going to visit the latest in patient care, a combined unit that serves the needs of both neurology and orthopedic patients. In an earlier broadcast, I visited with Dr. Sanjay Singh, a neurologist from Creighton University. He had this to say about the combined unit. I know that changes in lifestyle are often apparent with a neurological disease. I was intrigued that I believe you share some space with the orthopedic area.
Yes.
And tell me about that. Why would you share space with orthopedics?
So yeah, let me tell you a little bit about the Neuro Center. At Creighton, we are developing a brand new floor of caring which will be dedicated towards neurological disorders. We are also building a brand new neurology clinic, which is going to just deal with patients with neurological disorders. And we're also renovating the department where a lot of our faculty and staff and research is going to happen. So we are really building things brand new, and everything should be done by May or June of this year. So it is a very exciting time. And it tells us that Creighton has put a lot of stock in treating patients with neurological disorders. And this is something that is really significant in the field of neurology and neuroscience as a whole. What is the reason that we are sharing some of this space and resources with orthopedics? Because patients with orthopedic disorders and neurological disorders have some similar needs. They may be immobile. If you've had a stroke and you're paralyzed, you're not able to walk and move as you should. If you've had a fracture of your leg, you're not able to move. So both of these patients would need a lot of help from physical therapists, occupational therapists. And so as we are building the new neurology, neuroscience floor, what we are doing is that we have the rehab center right there on the floor so that the patients are not being wheeled to great distances to get these therapies. It's right there, right next to them. The whole neurological setup, the whole neurological center with the outpatient, the inpatient, and the departments all contiguous with one another. So it's a remarkable new thing that's happening at Creighton. And it really speaks volumes of Creighton's investment and Creighton's dedication towards treatment of neurological disorders.
It's sometimes a disease, sometimes referred to as a disorder, and sometimes referred to as a condition. What is the difference between a neurological disease and a neurological disorder?
So epilepsy should be correctly referred to as a disorder. Parkinson's should be correctly referred to as a disease. And the reason for that is that Parkinson's, there is a specific problem in the brain where the dopamine cells are dying off, and that is the single process that causes Parkinson's, and that is why it is called a disease. Single problem causing a single effect like Parkinson's. Whereas epilepsy is a disorder. Why? Because several diseases cause epilepsy. If you have a brain tumor, that will cause epilepsy. Head trauma damage, that will cause epilepsy. If you have malformation of the brain, that will cause. So several diseases are leading to epilepsy, and that's why it's called a disorder. So the correct terminology would be epilepsy is a disorder, Parkinson's is a disease. Some people ask about what's the difference between seizure and epilepsy. I have a seizure, but I don't have epilepsy. Anyone who has 2 or more unprovoked seizures, by unprovoked I mean not under the influence of drugs or alcohol, so more than 2 unprovoked seizures qualifies for the definition of epilepsy. So epilepsy is a chronic seizure disorder. So if you've had just 1 seizure, you have seizures. If you've had more than 2 or more seizures, you have epilepsy.
Thank you. I'm with Dr. Ian Weber, an orthopedic surgeon at Creighton University Medical Center. When I was younger, I thought you went to orthopedic surgeons only if you fell down and broke a bone. But why do people go to orthopedic surgeons today?
You're exactly right. I mean, most people, if they do get an injury like that, they end up seeing us, and we do fix a lot of bones from the injuries around the community and elsewhere. But as people start aging, they start getting arthritis, and they come to see us for issues about their joints as well.
So not just the bone, the joints around the bone.
Absolutely.
All right, like what happens, just for instance, which will probably surprise you, I do high impact aerobics 4 times a week. Do I need to be worried about what's happening to my joints and bones?
I tell people to do what they want. If they enjoy activities such as running and aerobics, do it. When you start getting a little bit of knee pain, then we may have to modify some of these activities or even maybe lessen the impact on these activities. But for the most part, our job is to keep you moving, keep you healthy, and keep you mobile.
Tell me about your patients. Who comes to you? What are the various things that people come to visit an orthopedic surgeon about?
Like you've said before, people will come for their broken bones, from their injuries, from their accidents. But again, we see a lot of people with knee pain, a lot of people with hip pain, and those ages are even getting younger and younger as people want to stay more and more active.
Why did an orthopedic specialty appeal to you?
Orthopedics really appealed to me probably when I was in medical school. It was very satisfying seeing people who came in with the inability to walk or tremendous amount of pain, and then within 6 weeks to even 3 months, they were already much better than they were before.
What areas of specialty are there within orthopedics?
Within orthopedics itself, it is divided, subspecialized in ways. For instance, we do a lot of joint reconstruction, so there's these joint reconstruction surgeons on our team, which I'm one of them. We have traumatologists.
Oh, a traumatologist.
Absolutely.
Tell me what that is.
This is where those high energy injuries, multiple extremities that occur, they end up putting them back together. Pelvis, acetabulum, legs, everything.
That brings up a good point. Creighton University is a trauma center, correct?
Yes, absolutely.
So I've done some shows on that, and I believe that these surgeons have the ability to kind of come in and assess when someone comes in. There's a large x-ray machine that allows you to access it.
Absolutely. People come in from a trauma from the outside. We're a level 1 trauma center, which means we have multiple teams here at all times. Neurosurgery, general surgery, and the orthopedists. And usually those people are assessed in the trauma bay, and at that point, yeah, you're absolutely right. We have large x-ray machines that help us definitively diagnose what the injury is. Sometimes you don't need the large x-ray machine. You can almost see it yourself, and then we go to the OR.
Oh my gosh. So an orthopedic surgeon, okay, you mentioned them, that you do the knees and the joints. There's the ones that's trauma. What are the other specialties?
Well, we have hand surgeons, and we have some people who...
Hand surgeons?
Yep, absolutely. This is just a specialty in itself. And some hand surgeons will combine the hand and the entire upper extremity. But this is a subspecialized area of orthopedics as well.
My. So a hand surgery would happen, what, if it got caught in an auger or?
That would be the traumatic, but there's a lot of daily activities that cause people to have hand pain. Carpal tunnel, trigger fingers, arthritis in the joints, just like we take care of arthritis in the hip and knee.
So when you went to medical school, did you do so many years with this and then you decided to focus on knee reconstruction and you did
Absolutely, yes. We go through a medical school curriculum, and then we went through a residency, and then after that you have the ability to specialize in what we call the fellowship. And I did a fellowship in both joints as well as trauma.
Well, because I'm kind of at that age, let's spend a few minutes on joint and knees. In the olden days, did you used to do reconstruction of the whole thing? The whole knee, and now you just do partial? Or when do you decide one a partial and one a full?
Absolutely, and that's really, we're starting to probably do more partials now than we've done in the past, because when you're doing arthritis, it doesn't necessarily mean all 3 compartments of the knee are affected. Possibly one versus the other is more affected. And if you're young, sometimes it's best to just partially replace it so that you can stay very dynamic and very, very active. And that way you won't even know you had a knee replacement. Other times though, if all the compartments are involved with the arthritis, we have to replace the whole thing.
Is osteoporosis another reason that those joints would disintegrate?
Not necessarily. Osteoporosis, we see that more on the trauma side. Those are more of these people who've come in with hip fractures or distal radius fractures or even compression fractures of the spine. Those tend to be the problems that we see with the osteoporotic patient population. And of note, actually osteoporosis, the benchmark of research was actually done here at Creighton.
Well, let's go back to the partial and the full. When you say replace it, what are you replacing it with?
Well, we replace it with metal. And we usually cap each side of the joint, and then we usually put some type of bearing surface, which is usually a plastic component between the two, which allows a frictionless motion or movement to allow the patient to have a joint that feels and acts more normal.
And that could work for years and years and years.
You know, it's exciting. I mean, the new surfaces that we're using now have been out for relatively a short period of time in orthopedics, 7 to 8 years. And we're hoping that these surfaces will last up to the 20s and maybe 30 years out.
If I start to feel the signs of distress in a knee, when do I come to you, or do I try something else first?
The signs of arthritis that most people will start feeling are in the morning, they're tight, it's stiff, they get up, they walk a little bit, it loosens it up, and then if they do too much during the day, a little swelling, a little bit of pain. At that point, it's a good time to have a conversation either with your primary care doctor or make an appointment to see us. We usually try to do what we call conservative or non-operative treatment first, and we have multiple things we can do there before we ever have to discuss surgery.
What are some of those?
Those are where we modify the pain with some different over-the-counter medications. We've also tried some pharmaceuticals where we'll use glucosamine and chondroitin sulfate, and even other times we may even do injections.
What about like massage therapy and seeing a PT and yoga
Absolutely.
and those types of things?
One of the best ways to slow the progression or decrease the symptoms of arthritis is to stay strong, is to keep your muscle strong. The stronger your legs are, even in the face of arthritis, the less pain you probably are going to have. The other thing that happens with arthritis is you get stiff. And when you become stiff, now you have pain not because of just the arthritis process, but because you've let the joint not move normal. As long as you have arthritis, you can still keep the joint moving, and that decreases the symptoms.
My mother spent her final years in a wheelchair. She couldn't walk, and she'd had some back surgery and couldn't walk. And so both of my sister and I feel that we could be candidates for the same thing. So that's why it's important to us to exercise, and we sure hope we're doing the right thing.
There is a large genetic component to arthritis that we haven't quite figured out yet, but you'll hear that time and time again. My mom, my sister, my brother, they all had knee replacements. You see that continuously within families.
I think that's important to all families too, is to talk a little bit about sports. When do you know if you're, I have a grandson it's a pitcher. He's 14 or 12, and I'm worried about him overextending. Should he be seeing a physician to make sure he's not overextending at this point?
These are things that we've all started learning more and more about with children who are pitchers. There's a little leaguer's elbow and as well as the shoulder.
The shoulder.
And absolutely. And so what they've done, at least within the sports, they've limited the pitch count or the number of times a certain player can pitch. So I think the organizations in different sports have done very well.
The organizations are interviewed.
Right.
That's good.
But if there's any sign of pain, it is probably something that's always worth getting checked out.
Is there any new technology you're using here in the hospital? Are you using as you do your surgeries?
Yeah, I mean, here at Creighton, we do use the computer for our knees, and that's what we call navigation, and we think that makes a more accurate cut and more placement of our components within the knee. Every year it seems like something else comes out, and at Creighton we're lucky. We usually end up getting that right away.
Now, we're going to visit the combined neurology orthopedic unit here in just a minute. In fact, we're in a corner of it right now. How is the recovery with orthopedics? What, do you just send somebody home after they've had the knee replacement, or how important is the recovery to the success?
The recovery is probably just as important as the surgery. And you have that early period where you really have to regain your motion, and that takes a lot of determination as well as a lot of coaching. And that's where we use our physical therapists. And here we have our own private physical therapy gym, which really takes the patient 2 to 3 times a day, which is excellent. Not only working with them, but then teaching them the home program that they're going to have to do at home. And so no, it doesn't just stop here, because after here, then we extend that out to our physical therapists in the community.
Well, that's great. Thank you so much for talking with me this morning.
Oh, you're welcome.
And when we come back, we'll visit more of the unit. I'm with Beth Gard. She is a nurse at Creighton University Medical Center, and the term that describes her best is a nurse navigator. Beth, that is a new term we're hearing more and more. What is a nurse navigator?
You know, within the field of orthopedics, which is what I'm the nurse navigator in, we take patients from the pre-op process. If they know they're coming in for a planned surgery, we do a joint camp, which is an education class prior to surgery, where patients and their family members and friends can come in and kind of learn about the process through the stay in the hospital. So every day they're here, I do the education with the patient to prepare them best for home or to a skilled facility, whichever they choose. And then after discharge, still following up with that patient. So making sure that the whole process is smooth and that the education is done, navigating them through it all.
I bet to the family and particularly to the patient, that is, it's wonderful because you are the one stop.
Absolutely. The patients have my cell phone number for night if they have questions. You know, the one thing we always see in the hospital is the moment the doctors leave the room, that's when all the questions pop up. And so being able to have somebody as that primary contact really does help.
We just visited with Dr. Weber, and he mentioned the team of professionals that take care of someone. Let's just use an example of someone coming in for knee replacement. Let's kind of take a start to the beginning and tell me about the various healthcare professionals that come into play.
Absolutely. It's a very large multidisciplinary team. From before surgery, working with the surgeons and the nurses down in the office itself, to going to the pre-op class with myself and a physical therapist. Patients then come to the floor and start with physical and occupational therapy daily on the floor. 3 times a day they're doing therapy. Respiratory therapy if they have any breathing issues from before, asthma, something like that. Speech therapy if they have issues previously from swallowing or things like that, to work with them there, as well as an orthopedic trained nursing staff, as well as orthopedic trained nursing aides.
I'm going to go back to the beginning and kind of talk about each one of those pieces.
Sure.
One of the things that surprised me, what you just said, was respiratory therapy. Why would they need a respiratory therapist?
You know, we see more and more patients that come in with maybe sleep apnea, and so being able to specialize the treatment of even just the sleep apnea in here. When you put somebody under anesthesia, they can sometimes have greater issues than they have at a normal night sleeping. So our respiratory therapists are on staff to come over and set up their machinery if they have asthma, to give them their inhalers and to watch it very closely throughout their process here.
Now, I'm assuming the speech therapy will come in more to play, not with the orthopedics, but from the neurology.
Absolutely. We see, especially for patients that have had strokes in particular, having issues speaking and swallowing and kind of relearning the process, speech therapy works with them very closely one-on-one to redevelop those skills.
Tell me the difference between a physical therapist and an occupational therapist.
Absolutely. That's a very common question. So occupational therapy works more on a patient's activities of daily living, and what that can mean is how to get dressed in the morning, how to get in and out of the bathtub, how to cook in your kitchen anymore, so things that we have to do every day to get around. Whereas physical therapy is more of a strengthening aspect of teaching them how to rewalk or teaching them how to go upstairs and downstairs for that matter, those basics.
Now, I'm assuming this machine we're standing at now is to teach mobility, the walking again.
Absolutely. This is parallel bars is what it's called, and the patients can use this instead of a walker to walk up and down, and kind of the therapist can evaluate in a better function and being able to see what they can do holding on to a couple bars versus just a walker.
Is the patient really, is it so much pain or is it apprehension when they start their therapy?
Sure, a lot of it is apprehension. You know, there's pain with any type of surgery, and joint replacements, like I said, it's not going to be no pain, but it's controllable pain. Mm-hmm. So the pain you're having is most of the time less for patients than what they came in with. A lot of patients have had very chronic pain issues with arthritis in their knee or hip, and when they come in, the initial day you have incisional pain, so the pain right where they did surgery, but the next few days they're building it up to the point where it's actually better than prior to surgery. About 2 weeks to 6 weeks before the pain is fully gone, and you're starting to feel like a brand new person, you know.
They say it makes perfect sense to put the orthopedic rehabilitation and the neurologic rehabilitation together. Talk to me a little bit about that.
Absolutely. A lot of the issues that you have are the same or common. In orthopedics, even if it's just a joint replacement, you are reteaching yourself how to do things every day. If somebody has a total hip replacement, there are precautions that go along with it, where you can't flex your hip greater than 90 degrees or bend all the way down or cross your legs, or, you know, basics like that somebody needs to relearn how to get around the house without doing something like that. A patient who's had a stroke may have lost function on one side, or, you know, in general lost function in areas, and they need to relearn to do these things as well. So maybe not as severe with the joint replacement patients as it would be with a stroke, but some of our traumatic orthopedic patients who have had spinal injuries need to relearn these things as well.
What are some, you mentioned stroke, what are other reasons that a neuro patient would come here? What other things?
Sure, we have a specialist, Dr. Sanjay Singh, who brings in patients for 24-hour EEG monitoring. So these are patients that have epilepsy or are thought to have epilepsy, that they will come in and be monitored for 24 hours for usually about a week, which is where we attach all little fun things to their head and watch and hope that they would have a seizure so that we could catch it and figure out where exactly it's coming from and how to treat it.
Oh, that's wonderful. Well, can you show me around?
Absolutely.
All right, Beth, here we are at the bathtub. Tell me about this.
Absolutely. We simulate the environment for home as much as we can within the hospital, with a shower, with a toilet, all those things, as well as the bathtub. going over with the patients, figuring out if they need handlebars at home, if that's something they'll need, depending on how low their tub is. We see patients more with lower bathtubs if they have them. So talking about the different devices that we can place on the tubs to make it safe at home.
How do you teach someone how to unload the dishwasher, for instance?
Sure, our occupational therapist would bring them into this kitchen to kind of do a simulation process of what home would look like. So if we have a total hip replacement patient unloading the dishwasher, we wouldn't want them to go past this 90-degree angle of the hip, which would be causing a hip precaution. So breaking our hip precautions. So patients could load maybe this top part of the dishwasher, and in the beginning at least needing help to load the bottom, if not bending one knee down to get to that point without breaking those 90 degrees. And it's a very great place, especially for our stroke step down patients as well. I mean, relearning if they're not having sensation in their hands, relearning how to be careful around the stove. The stove is not working, it's not going to burn the patient, but as you're watching the patient bring a pan over, you can see where they're crossing and, you know, kind of reiterating the points to the patients.
Because they have no feeling.
Exactly.
Very interesting.
As well as, you know, just in general, that's
general
basics. Yeah.
Okay.
This is one of our rooms that are geared towards our orthopedic patient. They do have lifts in the ceilings in case the patient has issues getting out of bed. It helps to, you know, decrease the risk of patient falls, save nursing backs. I mean, the whole deal. We have wider rooms so patients can get in and out with their walker, and specialty beds for these orthopedic patients.
Beth, I noticed when I walked in the room, there was a photograph on the bed. Tell me, who are the people in this photograph?
Sure. Creighton has implemented something called color by discipline. So the different specialties of your multidisciplinary team all wear certain colors. In the hospital environment, so many people come in and out, from people drawing your blood in the morning to people transporting you down for an x-ray, that we've really geared it towards different colors meaning a different person, as well as them coming in and introducing themselves. It kind of just gives you that color means that person, and it helps the patients out quite a bit. And a legend on the back that talks about this person's housekeeping versus therapy and nursing. And this photo is of the team that works here, nurses on the unit, transport here, respiratory therapy. This is simulation stairs. It plays a very important role in the joint recovery for the patients as well as in the camp, making sure the patient can safely get upstairs to be able to go home. Very rarely do we find patients that have no stairs to get into their house or get around anymore. So this is our way of being able to test the safety.
I heard you mention joint camp. What happens at joint camp?
You know, we have two different sections of joint camp. One is the pre-op class where the patients and families come in and learn as a group on joint replacement and what's going to be occurring throughout their hospital stay and afterwards as well as the exercises that we want them to do to strengthen prior to surgery. The other aspect is that the patients have the opportunity, if they want to come in and do therapy as a group in a session while they're here with our therapist. They also have the option of individualized therapy one-on-one.
Is it more fun to be with other people?
I think so. I think a lot of people enjoy that. But for some people, it may not be their initial joint replacement. They may be getting a revision. We do have experts in that here. We have surgeons that just do revisions here at Creighton. So maybe joint replacements that didn't work from previous years past, and they know about our specialist doctors here to come and get revisions. And for some of them, therapy is a little bit more difficult the initial few days, so they like to be individualized.
Now, a revision, I haven't heard that term before. So that would be as if you've had something done and you just need to go in and tweak it, or are you replacing again?
Some can be replaced, some can be tweaking. It just depends. Everybody's a little bit different with that.
So now the patient has had the surgery. They've learned how to rehabilitate themselves. When does your care continue on when they go home? Or?
It does. I call the patients the day after they're discharged, depending on where they go. If they go home, I talk to them specifically. Otherwise, if they go to a skilled facility, I talk to the nurses and sometimes the patients there, depending on how they're feeling. And it's more of a check-in process, see how things are going at home, if they have questions or concerns that maybe we missed in the hospital or new issues that have come up once they get home. That's the other part. And then they follow up with their primary care doctor as well as our surgeon after surgery.
Are most people surprised at how quick the recovery is?
Absolutely. It's a very scary thought to come in and have surgery, especially if you're a young, healthy person, and that all that it is some arthritis that's been bugging you. So the thought of this surgery is very scary and daunting on people, and then when they come in and they get it done, the majority of them are just as pleased as can be.
That's great.
Absolutely.
If you're interested in visiting one of Creighton's physicians, please call the number that appears on your screen. Take good care of your bones, and they'll take care of you for a long, long time. On behalf of all of us at Creighton, thanks for watching.